every second counts in the ICU, and that starts with your baseline monitoring. The standard fever threshold we're looking at is 38.5 degrees Celsius. For arterial pressure, you need at least hourly non-invasive checks, though obviously patients on vasoactive drips are going to need continuous direct monitoring through an A-line. We also frequently use central venous pressure, or CVP, as a handy surrogate for volume status. And here's a quick caveat about pulmonary artery catheters. Yes, they give us excellent data like mixed venous oxygen saturation, but, and this is a big but, their routine use actually hasn't been shown to improve mortality, so keep that in mind. Now, when it comes to sedation, the evidence is super clear. Outcomes improve when we use less of it. Nurses actively titrate these doses to a specific numerical target on the Richmond Agitation Scale, or RASS. The goal here is a calm, cooperative patient. We're typically targeting a score around 0 to -2. What we absolutely want to avoid is a heavily comatose patient, because that just delays weaning and rehabilitation. So, comparing our key sedatives is really essential for those rapid bedside decisions. Take midazolam. It acts via GABA receptors, but it has hepatically cleared active metabolites that can dangerously accumulate. We're talking days to clear, especially during prolonged infusions. Propofol, on the flip side, acts incredibly fast because it's highly lipophilic, but you have to watch out for profound hypotension from myocardial depression. Plus, you always have to be on high alert for propofol infusion syndrome. That's going to show up as unexplained metabolic acidosis, rhabdomyolysis, and arrhythmias. What's really fascinating right now is the massive rise of dexmedetomidine. It's a centrally acting alpha-2 adrenoreceptor agonist, and it's increasingly favored in ICU protocols. Why? Because it almost magically provides both sedation and analgesia without depressing respiration. No respiratory hit. This makes it absolutely ideal for keeping your patients calm during spontaneous breathing trials when you're trying to transition them off the ventilator. Moving on to respiratory failure, you've got to immediately distinguish between two major physiological disasters. First is dead space. That's ventilation without perfusion. Think of a massive pulmonary embolism, completely blocking blood flow to perfectly aerated alveoli. An intrapulmonary shunt is the exact opposite, perfusion without ventilation. The classic textbook example here is acute respiratory distress syndrome, or ARDS, where blood is just flowing right past fluid-filled, collapsed alveoli without picking up any oxygen at all. And that brings us to the primary divide in mechanical ventilation modes. Volume-controlled modes like assist control guarantee a set tidal volume so you know you have adequate ventilation. But if those lungs are stiff, they risk causing dangerously high airway pressures. Pressure-controlled modes, on the other hand, cap that airway pressure to protect the lungs. The trade-off? They risk dangerously low tidal volumes if the lung compliance suddenly drops. It's a balancing act, and you have to pick your priority based on your specific patient's lung mechanics. Speaking of ARDS, survival absolutely depends on a strict lung protective strategy. The ARDS-NET trial totally revolutionized this. They proved you must use low tidal volumes. We're talking exactly 6 ml per kilogram of ideal body weight. You also have to adjust this to maintain plateau pressures strictly under 30 centimeters of water to prevent barotrauma, all while making sure your PEEP is kept above 5 to prevent alveolar collapse or atelectasis. But what happens when conventional ventilation fails in severe ARDS? Well, we move straight to rescue strategies. The pros of a study showed a real survival advantage to placing the patient in a prone position. Flicking them over recruits those dorsal lung units. Also, instituting continuous neuromuscular paralysis with a cystatrachurium infusion has been shown to improve survival in severe cases. It perfectly synchronizes the patient with a ventilator and significantly drops their oxygen consumption. Okay, so when it is time to actually take that breathing tube out, how do you know if the patient's ready? You calculate the Rapid Shallow Breathing Index, or RSBI. It's just the respiratory rate divided by the tidal volume. The absolute magic number to remember here is 105. If that value is greater than 105, it strongly suggests your patient is breathing too fast and too shallow, meaning extubation will very likely fail. Let's shift gears to circulatory failure, or shock. Before you even identify the specific type of shock, you have got to secure global oxygen delivery. Instantly aim for an oxygen saturation above 92%. Ensure their hemoglobin is adequate based on a strict 7 grams per deciliter trigger, and immediately hit them with a 10 to 20 milliliters per kilogram crystalloid bolus. The only time you hold back on that fluid, if the patient is in frank cardiogenic pulmonary edema, of course. Now we've got absolute hemodynamic profiles for the 4 major shock categories: hypovolemic, cardiogenic, septic, and neurogenic. Recognizing these distinct hemodynamic signatures, meaning cardiac output,
wedge pressure, and systemic vascular resistance is totally non-negotiable for rapid bedside diagnosis. You have to know these cold.
Let's quickly decode that data. Hypovolemic shock features a decreased cardiac output and a compensatory increased systemic vascular resistance. Basically, the body is clamping down hard to maintain blood pressure. Distributive shock, like you'd see in early sepsis, is the exact opposite. You'll see a hyperdynamic, increased cardiac output coupled with massive, dangerous vasodilation, which just plummets that systemic vascular resistance.
For septic shock, time is tissue. The algorithmic sequence here is incredibly strict. First up, draw percutaneous blood cultures. Second, get those broad-spectrum IV antibiotics in within 1 hour. And yes, that is a heavily tested quality metric. Third, aggressively resuscitate with IV fluids. And fourth, if they're still hypotensive despite all those fluids, you start vasoactive medications. Norepinephrine is overwhelmingly your favored first-line agent here.
Now, the use of steroids in sepsis, highly debated. They definitely increase the risk of secondary infections, which isn't great. However, current consensus dictates that moderate dose hydrocortisone should absolutely be given for septic shock if it remains completely refractory to adequate fluids and high-dose vasopressors. It really does aid in the faster resolution of shock. What about obstructive shock emergencies? These will not respond to fluids and pressors alone. They require immediate mechanical relief to restore cardiac output. Attention pneumothorax, that demands instant needle decompression followed by a chest tube, pericardial tamponade, needle decompression, and drainage. And a massive PE requires really aggressive intervention, ranging anywhere from systemic anticoagulation to thrombolysis, or even a surgical embolectomy. Regarding general ICU targets, we have to talk about anemia. The landmark TRISEC trial definitively set our restrictive transfusion trigger at 7 grams per deciliter. Listen to this. Transfusing critically ill patients to a normal hemoglobin actually harms them. The only exceptions to this strict rule are patients with active myocardial ischemia, severe hypoxemia, or an ongoing active hemorrhage. Similarly, we've learned a really hard lesson about blood sugar. We used to strive for super tight glucose control, between 80 and 110. But studies prove that this causes lethal hypoglycemia and actually increases mortality. Nobody wants that. Instead, current guidelines support a safe and beneficial blood sugar target of simply less than 140 milligrams per deciliter. Keep it simple, keep it safe. Stress ulcer prophylaxis is another perfect area where less is more. You should only prescribe H2 blockers or PPIs for specific proven risk factors. Think prolonged mechanical ventilation, traumatic head injuries, major burns, or coagulopathies. Why? Because blanket overprescribing of acid suppression actively alters gut flora, and that drastically increases the risk of life-threatening C. diff infections. Finally, looking at critical care medications, understanding the receptor action profile changes everything. Notice that phenylephrine is a pure alpha agonist. It strictly clamps down vessels, but be careful, it can cause reflex bradycardia. Norepinephrine, our absolute sepsis workhorse, provides potent alpha vasoconstriction, but importantly couples it with essential beta-1 inotropic support to keep that heart pumping effectively. There are also some really crucial clinical caveats that you will encounter on the wards and, for sure, on your exams. For instance, you must immediately decrease lidocaine doses in patients with hepatic failure to avoid toxicity. Also, definitely avoid nitroprusside in patients with renal failure. Its metabolites will dangerously accumulate and lead to fatal thiocyanate toxicity. Let's tie this all together with a rapid board review application. Imagine you have an ARDS patient on positive pressure mechanical ventilation. Suddenly, out of nowhere, they develop severe respiratory distress, hypotension, a high CVP, and unilaterally diminished breath sounds on the right side. What must you immediately do? Take a second. Think about the physiology of the ventilator modes we just discussed. Did you get it? The immediate action is needle decompression followed by a tube thoracostomy. You have to recognize that the high plateau pressures and positive end expiratory pressure required for ARDS caused barotrauma. It ruptured an alveolus and created a life-threatening tension pneumothorax. That is obstructive shock right there. So I'll leave you with this final thought. Beyond just knowing the vent settings, how well do you actually know your ventilation complication algorithms? Because in the ICU, recognizing the crash is what actually saves the life.